Thanks very much. So this paper is not so much about sharing findings, but more talking about methods and reflection on methods. In particular, interviewing older men about the topic of loneliness and social isolation in later life. And I'm going to talk briefly about a background to the study, why focus on older men, what we mean when we talk about isolation and loneliness. I'm going to talk about the research design, the aims of the study, and a little bit about progress to date. And then I'm going to talk about some of the challenges that we've encountered in doing this project so far, and particularly reflections and challenges on the interview process. And the project that I'm going to talk about, just to acknowledge, is funded by NIHR SSCR, is in partnership with Age UK, and is a part of a team of investigators, including David Abbott and Tricia Jesserman in the School for Policy Studies at the University of Bristol. But first of all, why loneliness? Well, we don't have to look far to see headlines in the media about loneliness. We know it's a social issue which is receiving a lot of attention, both from the media and also from political actors as well. And this headline here, not just the BBC, but many other headlines describe loneliness as an epidemic, or a phenomenon that's reached epidemic proportions. And alongside these headlines, we could see there's lots of political work happening around addressing loneliness. So we've got the work of the Joe Cox Commission on Loneliness, which Age UK is involved in, and more recently the appointment of a new Minister for Loneliness, taken up by Tracy Crouch just a few months ago. So we also know that there's been a lot of research findings about the prevalence of loneliness, particularly amongst older people. So Age UK, for example, they suggest that over 1 million people aged 65 and over in the UK are always or often lonely. And this is countered by other arguments that say, well, yes, we do have an ageing population, and therefore we are going to see an increase in the prevalence of loneliness amongst this increasing group. But others, such as Christina Victor, argue that the prevalence of loneliness among 65 and over has been fairly steady over the last 5 decades. So there's disputed evidence about increase of loneliness. And of course, other people argue that we also need to think about how loneliness affects all different age groups, not just older people. Just a little bit of definition clarity. Talking about loneliness and social isolation and living alone as 3 separate constructs, or 3 separate ideas and issues. So of course, you could be living in isolation or in an isolated area, but you may not be lonely. Likewise, you can be living in a busy household or living in a major city like London, and surrounded by people and groups and various social networks, but still experience profound loneliness. But we also know that social isolation and loneliness are connected. So, for example, living alone for older people is recognised as a risk factor for increasing the likelihood of people experiencing loneliness in later life. But when we talk about loneliness, we're talking about a subjective experience, a felt experience, where we have a desire between the current social networks I enjoy or I'm part of and what I want my social networks to look like, or the amount of social contact that I would like to have a look at, I'd like to be involved in. And we can talk about emotional and social dimensions to loneliness. So emotional loneliness may be connected to a loss of a significant other or a partner, say for example through bereavement, whereas the dimension of loneliness is about a person's particular social network and who's part of that social network, and what we might want that social network to look like for ourselves. Social isolation is more of an objective state, something that we measure about the absence or the number of contacts we have with people across our social networks. And it can include aspects like separation from community involvement, as well as lack of services, which can increase or heighten social isolation. So we know there are lots of risk factors associated with loneliness and social isolation, and lots of research to help us identify what these risk factors might be. And Christina Victor and others have talked a lot about loneliness, social isolation, and living alone as separate but overlapping. They can mutually inform each other in terms of heightening both loneliness and social isolation. And for older people, there are a lot of transitions associated with older age, which can increase or decrease experiences of loneliness. So significant changes like retirement, changes in accommodation, for example, transitioning from hospital care or home care to a care home, demands to give or receive care, bereavement, particularly if that's about being a widow or widower, and ill health, both short-term and chronic health problems. Victor and others also identified these 4 different domains of risk factors, just to give us a sense of how what these different risk factors can look like. So they could be socio-demographic, such as not being married or not being in a relationship, living alone. They could be material related in relation to housing tenure or education level. They could be health factors, for example, having a chronic illness or living with sensory impairments. Or they could be related to social resources, so the availability of confiding relationships, the number of relationships we have for people we could look to for affective or emotional support. And other factors like our social capital, and also belonging to a minority group and being part of what's perceived as a social minority. In this particular project that I've been working on, that we're halfway through, we've been focusing on older men. And there's lots of reasons why we're focused on older men. Because we know that in comparison to women are more likely to have wider social networks than men across the life course. And there's a recognition that, particularly in heterosexual relationships, that women are often much better at maintaining and nourishing social networks than men are in those same relationships. And we know that men in heterosexual relationships may look to their female partner or wife to keep up the contact with friends, to organise contact with family members and friends on a regular basis. So women, if you like, providing the social glue in those relationships. Women, as I said, are more likely to be reliant on their female partner for maintaining those networks. Older men are also less likely to have contact with friends, particularly monthly contact. And a greater percentage of older men, 50 and over, report moderate to high levels of social isolation. And this is higher for older men without partners, who report particularly high levels of loneliness and isolation. And there's been some great research recently from ILC UK bringing attention to men's experiences of loneliness and isolation. We also know that from research and evaluations that older men are less likely to access older people's services, such as day centres or social clubs. Lots of different reasons. Some of those reasons can be about feeling that the service is feminised, that doesn't appeal to men or doesn't appeal to men's interests, or perceived to be women-dominated. And we've seen the phenomenon of men's sheds, which has started in Australia and is now quite popular in the UK as a way of counteracting some of those concerns about older people's services being of more interest to women than men. So this study is called Older Men at the Margins. We're about halfway through. And the overarching objective is about developing an in-depth understanding about the formal and informal ways in which hard-to-reach groups of men, 65 years and over, seek to maintain social engagement in later life and combat loneliness. And this includes experiences and participation in group interventions and community-based groups that seek to reduce loneliness for older men or for older people, which include older men. The specific aims of this particular study, we want to develop a deeper understanding of how men from hard-to-reach and marginalised groups experience loneliness. What does that look like? And how do they combat loneliness? How do they keep loneliness at bay? What helps to alleviate that everyday sense of loneliness? We're interested in the men who's taking part in their social networks, the current membership of their social network, and their social engagement with identified members, and who their sources of support are. And more broadly, we want to think about ways in which social care services can support older men to maintain social engagement and to keep up that contact with significant others. So these are the 5 groups that we classify for this particular study that we're looking at in terms of hard to reach or marginalised. So these are single or living alone, men who are gay or bisexual and single or living alone, men who are living in rural areas and single or living alone, men who are caring for significant others, like family members or partners, and men living with hearing loss. And we're focusing on these 5 particular groups, either because there hasn't been a lot of attention in the loneliness research or indeed ageing research about men with these particular statuses, thank you, or because we know that, for example, living alone is a risk factor, being part of a minority group such as sexual minority group can be a risk factor as well. So it's a qualitative study. We've recruited men from a whole range of men's groups, clubs, older people's community services like men's sheds, like walking football, walking groups. We've been using semi-structured interviews, one-off interviews with men to talk about their experiences of loneliness. And so far we've completed 92 interviews with men between 65 to 95 years, and we're currently focusing on our last group, which is men with hearing loss. Part of the interview is looking at men's social convoy, and this is based on Adanucci's model of social convoy as a protective foundation or a protective bubble that supports and enables us to cope with and manage stressful life situations. So your social convoy model is something that might change over the life course. There might be consistent elements of it over the life course, but it essentially encompasses your social networks, the people that you look to for day-to-day support. So we use that as a tool, as a visual mapping exercise and a way of stimulating conversation about men's social networks and the qualities of their relationships. It's been used predominantly with quantitative research, and we're using it here, again, as more about a tool to initiate discussion. So you can see here in the diagram, in the middle are the people that we cannot imagine living life without. In the second circle are the people who are close or important to us, but they're not necessarily mentioned in the first circle. And the outer circle is the people we consider important enough to be in our personal networks, but they're not as important as those people closer to the centre. So this is, I don't expect you to be able to read this, I just wanted to show you what it looks like at the end of an interview. You can't in itself ascertain a lot about what a person's social network looks like from this. It looks a bit random and disjointed, but it's very useful in terms of stimulating conversation about people's social networks. The coloured dots signify the level of contact or the frequency of contact with people on their social convoy model, and the lines denote where people look for effective support as well as practical day-to-day support. So one of the challenges we've had in this particular project is where some men had very few people on their social convoy model. So if we look at this gentleman's here, he had 5 people on his model, 4 of which are neighbours and 1 of which is a landlady. So there were no friends. This was a very short conversation. So that can be a challenge in itself, but can be equally revealing about perhaps the level of isolation that this particular person might be experiencing. The second challenge we have, of course, is discussing loneliness with older men. It's a highly emotive and highly sensitive topic. So we've given a lot of thought about how do we do this. Some of the solutions we have is about sequencing. So obviously we locate questions about loneliness midpoint or later in the interview. We start by asking externalizing questions about loneliness first. How would you describe loneliness? How does it make other people feel? And a lot of men come up with some quite profound responses about how they would describe loneliness. It doesn't necessarily mean they're experiencing this form of loneliness or that their experiences matches this, but it's a conversation starter to talk about what it might look like and how it might affect people. The other solution in terms of loneliness, in terms of talking about loneliness, is to use these 3 questions. This is from the UCLA loneliness scale. It's a very short scale made up of 3 items. Thank you. And it's built for a survey measure and for evaluation services, but we've appropriated it in the interviews. We found it a really useful way to kind of drill down into men's experiences of loneliness. And it can be particularly helpful when some people feel it reluctant to talk about loneliness directly, but these questions kind of open up conversation about different dimensions of loneliness without having to talk necessarily about being lonely or affiliate that loneliness identity with oneself. And the third challenge is about emotional responses, so distress and tears. So we have had quite a few men who experience distress during the interview. And this particular participant is talking about, they sent me this email response a week after the interview about how the emotions that are brought up for them participating in the interview, but how they ultimately found it a therapeutic experience. So this, oh, out of time, okay. That's all right. I'll stop there, sorry, I'm just going to stop. That's okay. So where to from here? We're just finishing off the field work for this particular research project. We're going to plan a series of workshops in the autumn that bring together professional service providers and community members to really nut out, well, what does this mean for both social care services and service provision more generally in terms of community services? We're going to work with UK to co-produce online resources and handbook directly for service providers about how they might tailor their services for different groups of men. We plan dissemination activity with Age UK, and we have a spin-off project which is bringing together my joy of going to the pub with the joy of doing research called Men in Pubs, which is going to look at pubs as social spaces for older men and the way in which they might help reduce loneliness. Thank you.
Do we have time for a question? I think. Again, just one. Could you just say your name first?
Yeah, my name's Smith from Manchester Metropolitan University and research in similar areas. But I was interested in your recruitment. Suggested that you've recruited from things like groups. So I wonder how you managed, or if you managed to get to some older men who were more socially isolated, who might not be a part of some of those groups.
That's a good point. We deliberately, as part of the research design, we decided to recruit only through groups and services that were already providing some kind of social-based intervention. So a consequence of that choice is that our sample won't encompass people who experience profound degrees of loneliness and isolation. Having said that though, like the gentleman whose social convoy map I showed before, and there are very few people on it, I think there are some of those people who are still in contact with services but may not feel that those services meet their needs, or may not engage with those services even though they might be on a mailing list, for example. But I completely agree with you that there is that other group that's not going to be captured through this particular recruitment pathway, and perhaps more creative methods of recruitment like GPs, post offices, post people, other ways of engaging those particular men through services that they might have more routine contact with.
Okay, maybe if it's a very, very quick question, we can take one more question, then we should probably move on.
Nice quick.
Thank you.
Yvonne Burks from York. Thank you. I was just wondering, and maybe you said it and I missed it, but I heard you say you recruited hearing impaired.
Yes, men with hearing loss.
Yeah. Did you include men with who developed visual impairment?
Hearing loss.
Yeah, but not people with visual impairment.
People with visual impairment are not excluded, but the criteria for recruitment is relation to hearing loss. That makes sense. Yeah.
Thank you very much.
Thank you.
And so next up we have Phillip Whitehead, and you're from Nottingham University. Is that right?
Yep.
And then we talk about the Bath feasibility trial.
So I'm in the first month of being an Associate Professor of Occupational Therapy at Northumbria University, but most of this study was completed at the University of Nottingham, which is why I've gone for quite neutral branding on the slides. So I'm going to tell you about a feasibility randomised control trial of bathing adaptations, by which we mean the removal of the bath and replacement with a level or accessible shower. And so I'm very grateful to SSCR for having funded the study, but it is part of my contract to say that if I do upset any of you in the next 15 minutes, it's nothing to do with SSCR or the Department of Health. Okay, so the bigger questions that we want to ask with this study is whether or not bathing adaptations improve older adults' quality of life and functional ability, and also whether they lead to reductions in the use of other health and social care services. So there's quite good anecdotal and qualitative evidence to show that they do, but there isn't much in the way of quantitative evidence or health economic evidence. And a secondary question that we're asking is also whether waiting times lead to poorer outcomes and increased costs. So what we know already is that housing adaptations have been identified as a top 10 prevention service for older adults. But this is a bit of an oxymoron because in certain local authorities people can be waiting up to 2 years for the adaptation. So on one hand we're saying it prevents further deterioration and service use, but on the other hand there's these huge waiting times. There's quite good quality evidence on the preventative effects of minor adaptations, so things like grab rails, altered steps and thresholds. We know that they reduce falls and they reduce the consequences of the falls in terms of the severity of injuries. But this systematic review that was published late last year has called for further research evidence from RCTs, particularly in the UK, on major adaptations, so things like we're talking about here, the removal of the bath and replacement with a shower. So bathing is particularly important in the trajectory of disability for older adults. We know that older adults who develop disability in bathing are 5 times more likely to develop a disability in another daily living activity the following month. We also know that bathing disability acts as a warning point for nursing home admission. But what we don't know, our systematic review completed as part of Bath Out, we only found one interventional study, so we don't know what happens if we actually intervene at the point of bathing disability, and so that's another thing that we're looking at with this study. So our method then, this is a bit of a mind map, but if we follow it through, within our period that we were open to recruitment, we assessed every referral that was made to the adaptations agency at Nottingham City Council. So the eligibility criteria was being aged 65 and over and referred for level access or easy access shower only, so not in combination with other adaptations. So everyone that consented had a baseline assessment and then was randomised by a web-based programme to one of 2 groups. One group over on the far side was the control group, which was a usual waiting time of 3 to 4 months before they were allocated to a project officer to start planning the adaptation. And the other group did not go onto that waiting list. They were immediately allocated to the project officer to start planning the adaptation. And it normally takes 4 to 8 weeks for the adaptation to go in. So we followed both groups up at 3 months. And the idea was that this group's had their shower and been using it for 4 weeks, and this group is still waiting. So we've got a direct comparator there. We then follow up at 6 months, by which time the control group have started to tick through and have theirs completed. And then we go again for a final time at 9 months, when the idea is that everyone's had their shower installed. So it's a feasibility trial, so we're really looking to see, can we use this method to conduct a bigger study where we would get some definitive results. So we're looking at the sort of things of whether our criteria are realistic, whether people are willing to take part, whether we can, what the loss to follow-up is, whether or not we can get the adaptations in within the timescales that we want to, and the suitability and sensitivity of the measures for use in the bigger study, and whether or not we can get the data we want to carry out a definitive health economic analysis. So I've gone quite quickly through that because I've got the results that I'd like to share with you. So this is my favourite slide. I've got it on a t-shirt underneath here. Any of you that have tried to recruit studies will know it's really challenging. We had a 40 to 60 target within an 8-month recruitment period, and you can see that we smashed the target. We got all 60 within 6 months, likely due to the fact that there was a real incentive for people to not go onto the waiting list. So a bit more meat on those bones. There was 75 people that were eligible during the time that we recruited, but the adaptations agency couldn't get in touch with 3 of them, and 6 of them declined for their details to be passed on to us. But all 60 who did have their details passed on to us and received the study information sheet, they all consented to take part and were randomised. 31 went into the immediate adaptations group and 29 into the control group. And then you can see the numbers that we followed at 3 months in both groups, in 6 months and at 9 months. So the 9-month follow-up was added in as an extra because we recruited successfully, so they had to reconsent at that point, so some of them chose not to, so that's why there were slightly fewer at 9 months. When you look at the results, these are the numbers that we're looking at. So this is probably very small for you to see. This is the baseline characteristics. The main thing that we're looking at here is the comparability between the two groups. They are very comparable. Slightly more men in immediate adaptations and slightly more people with a neurological condition as the primary diagnosis in immediate, but otherwise they're well matched. Average age mid to late 70s, and there's a mixture of housing tenures between local authority, privately owned and housing association. So our first feasibility outcome is whether or not we could get the adaptations in the timescales that we wanted to. So you remember we wanted it in before the 3-month follow-up in immediate and before the 6-month in the waiting list group. And you can see that on average we did do that at 2 and 5.6 months. But we were sort of 65% in both groups that were within the target. So this was slightly less than what we were. Our target was 70%. So some of the detail is that we got no housing association properties completed within the timescales. So there's an extra layer of bureaucracy with housing associations. We've got the way that it's paid for is a means-tested grant, which is means-tested on the person. But then we've got the housing association to administer that grant as well as the housing provider. So that did delay it. Also, some of the owner-occupiers didn't proceed because they had their means test and then decided not to go ahead with the adaptations. So excluding housing associations and excluding cancelled referrals, we got 85% of the adaptations within the timescales. So I'm going to show you the participant results now in terms of the suitability and sensitivity of the measures. So there's a couple of things to say. I'm presenting them in a bit of an unconventional way using graphs. That's because we're looking at what happened in both groups at different times. So the orange line you're going to see is the immediate adaptations and the blue one is the control group. So we're looking at whether or not there was an immediate improvement in the immediate group, and also watching what happened to the control group during this 3-month period, and then thereafter what happened to the control group, and also where they both ended up. The second thing to say is these are just descriptive, they're not inferential. We're only looking at whether or not the outcome measures seem like they're measuring the thing that we want to measure. So if anyone's tweeting, if anyone tweets and says this study is showing the adaptations are effective, I will retweet and correct because that's not what we're doing here. Okay. So this is the first outcome, which is physical health or well-being or physical quality of life, measured by the physical component summary on the short form 36. And what you can see is the improvement straight away, continuing in the immediate adaptations group, and we are seeing that deterioration in the control group during the 3 months that they've waited. It's worth also pointing out that they have waited prior to the point of randomisation for the OT assessment too. So if we can extrapolate what was happening during that longer wait, I think it is quite important. But in the control group, again, once the adaptations start to go in, we're seeing that improvement in physical functioning. So I'm going to go through the rest of the measures quite quickly. Just you can see the same again. This is the mental health component of the short form 36, so mental well-being. Again, flatlining in the control group during that 3 months, but some quite big improvements after the adaptations have gone in both groups. This is health-related quality of life on the EQ5D. This is important. This is the one that the health economists use to calculate quality-adjusted life years, and we've got some quite big increases in both groups after the adaptations. This is perceived health on a 10-point scale on the EQ5D, 100-point scale on the EQ5D. This is social care-related quality of life. And then this one is independence in bathing, so slightly different. You can see that there was less independence in the intervention group to start with, but a big increase after the adaptations, and same in the control group as well. This is our least standardised outcome measure. This was a 100-point scale. We just asked them for the perceived ease or difficulty in bathing. And you can see the scale, huge difficulty at the start and a huge increase reported by the participants after it's gone in. And then the final one, fear of falling. Obviously, this is inverse. Fear of falling is a negative outcome. So you can see fear of falling increasing during the wait in the control group and decreasing in both groups after the adaptations have gone in. We collected data on falls as well in both groups. There was a reduction in both groups at 3 months. That's because participants were probably more likely to have had a fall which precipitated the occupational therapy assessment and the referral for the adaptations. But thereafter, there were fewer falls and fewer participants reporting falls in the immediate adaptations group. So on average, the cost was just under £5,000 for the adaptations. We were able to collect a lot of data on health and social care resource use, what services they were using, and we particularly focused on personal care from paid and unpaid carers. What we did see was a particular reduction in the assistance from unpaid carers following the showers going in, so that increase in independence in bathing seemed to have come mainly from the unpaid care section rather than paid carers. So the final points then, these were the pre-specified targets in the protocol. We said we wanted to recruit between 40 and 60 participants, which we did. They were willing to be randomised, and we were able to follow up nearly 90% at 6 months. This is the query that I'll come back to, but we were able to collect complete outcome data responsive to change across the raft of measures and collect the data that we need for a definitive health economic evaluation. So we've got a question mark over the timescales. The way that I think we could get around this is to have that slightly longer waiting time. By 4 months, we would have got enough. We would have been able to get enough of the adaptations in that immediate group. We also need to think what we're going to do with housing associations in a bigger study. I don't think it would be right to exclude them, but we perhaps need to work a bit more focused with the housing association providers. And we could also look at randomising owner-occupiers after they've completed their means test. That would reduce the amount of people that didn't then proceed. So the conclusion is we think that we've showed that a powered RCT would be feasible, subject to those minor changes in trial design, which I've just mentioned. And I think the links between housing and health are really important, and there's really important public health and policy implications from this study. And I think the waiting times, the longer waiting times that we're seeing, that people are spending waiting for those adaptations are probably much more significant than we realise. So I'd like to thank the rest of the Bath Out team, and particularly thank all of the older adults and their carers that took part in the study. Thank you for listening.
Okay, so does anyone have any questions? You can mind say your name first.
Hi, my name is Devon from Holloway, London. I just wanted to thank you for the presentation. You know, when you did the measurement of the mental health and well-being, I was wondering what tool did you use?
That was also the short form 36. So the short form 36 questions about health, functioning and activities that have been completed over the last 4 weeks, and it then splits into some questions count towards physical health and some count towards mental health, and it calculates a score.
Is it like a form of question?
Yeah.
Thank you.
Any other questions?
I have a ulterior motive because I'm from the Ascot team.
Okay.
You mentioned social care as a right? Was it sensitive across more domains than you expected?
We haven't looked at it in terms of the individual domains yet. We've just calculated the but we've also done a qualitative study as part of the study as well. We've been talking to the older adults after the adaptations have gone in, and we're going to look in more detail in relation to the aspects that we've measured in the trial. So we want to make sure that we're measuring the things that they say important. So feeling safe is obviously a key aspect. Choice and control are really coming out really strongly from the qualitative data. So we then want to map that on to make sure that we're capturing the things that we think that we are. Absolutely.
Okay. When are papers like this come out?
So the paper from the RCT is under peer review at the moment, and the call we hope to submit shortly, so hopefully imminently.
Maybe just to highlight for people that I found a Twitter site for the actual project. You've got a Twitter account on the project itself. So.
You say your own name.
Sorry, David Abbott. I was just shoehorning that in.
Yeah, so it's at Bath_out, not hyphen, because Twitter doesn't like hyphens.
There are other questions. I have a question. I was quite interested in the informal carers and the finding that it has an impact on the amount of input the informal carers are giving. So the indication is that the way you're treating informal carers is an input. But I was interested in that decision and whether you thought about treating them as and looking at their outcomes actually from this as well.
Yeah, so we did. We have recruited carers as well. I haven't presented their outcomes, so I think 2/3 of the participants had a carer, and we recruited half of those that had a carer, so we've got about 20 carers. But then with the fact that the adaptations didn't all go in time, so the carer outcomes are a bit more, it's not as clear what's happened with the carers, but we did include them. But it was quite interesting that recruitment was more challenging for the carers, and where the carers didn't live in the house, the participants weren't necessarily keen for us to contact them.
So I don't know if there's any more questions, otherwise we can move on to the next speaker. Okay, thank you very much. Okay, so our next presentation, we have two So we have Frank Keating and from Royal Holloway.
Which one is it? Oh, that one. Yeah. Okay.
Maybe another slide.
Oh, okay. There we are. Okay. Thank you very much, and I'll do the disclaimer. This is my views and not the SSCR views. And the project, you will see that the project is done in collaboration with colleagues from Leeds, Beckett University. It used to be the Centre for Men's Health, which is now disbanded, but I'm still working with them. And we're in the final stages of the study, so this is a snapshot. And I'm sorry that there's 3 men and then there's a woman after us. I don't know how that worked. So, and that's my research assistant, Stephen, over there. So I'm going to briefly just tell you the design of the study and then, as I say, a snapshot of the findings. So the aims of the study was to identify what supports recovery for African and Caribbean men from a diversity of perspectives. So why am I focusing on African and Caribbean men specifically? I've done some work in 2011 really trying to talk to black and minority ethnic men around mental health recovery, about their understanding of emotional well-being. And the men who had contact with mental health services talked about something which we call a stalled cycle of recovery, and where men were just in contact with services continually and never reached a stage which they could call recovery. And so I was curious to know and to find out, are there some men who actually do find themselves in recovery, and what does that look for them? And so that's why I wanted to do this piece of work. And so it's also to look at how services across all sectors can be developed to support the men better. So just quickly, the study design. I was going to talk about the context, but I think we all know about the disparities in mental health for black and minority ethnic communities, so I'm not going to revisit any of that. So it was a participatory qualitative design. So that means that I had carers and service users involved from the proposal stage in the project all the way through to the advisory group as well. It's a multi-site study, so we had 3 London sites and then an out-of-London site which was in Leeds. And the study was conducted in 4 interlinking stages. So we started with the scoping of the literature, and unfortunately we could find loads of studies talking about mental health recovery, and we only found about 2 studies specifically looking at black men and recovery, so we felt there's a need to do this work. So the second stage of the study was then something which we called triad interviews. So what we did is we recruited men, African and Caribbean men, who had an experience of mental health problems, who considered themselves to be in recovery, to come and talk to us. And then once we've done the interview with the men, we'd ask them to nominate somebody in their life, a significant other person, who they felt supported their recovery, to go and talk to them. And then we also asked them to nominate a mental health practitioner who they felt supported their recovery. And this is where we had the most difficulty recruiting. The men didn't want to nominate a practitioner because they said, my recovery is my own journey, mental health services did nothing for me. And also, where they did nominate a practitioner, the practitioners were really worried about confidentiality in terms of talking to us. So we didn't really manage that so well. But we ended up with 59 people participating in our study. This was then followed up by, This was followed up by co-creation events. So what we've done is, once we've done the interviews, we did a first level analysis of the data, and we took the themes from the data to a small group of the men who participated in the study, and we presented the themes to them and asked them to turn that into messages for policy, research and practice. And then we followed that up with an expert symposium where we had service users, carers, mental health practitioners, policymakers, commissioners, and again, to talk about the findings. So the findings, first of all, just talking you through 3 main key themes. So the first one was, of course, one would expect that there were divergent perspectives on what recovery means. So for example, the men themselves were more aligned to what we call the social model of recovery, a recovery that speaks to their whole life, whereas their supporters, interestingly, and the mental health practitioners, or what we call their providers, were more aligned to a clinical model of recovery. And so there was a disjuncture between these 2 groups. And then also we talked to men about their challenges to recovery, and I will talk a bit about that. And then what are the enablers to recovery? So the findings. So our analysis revealed 3 domains, and we took what we call a life course perspective. And this is basically to look at how early life experiences informs current contemporary experiences. And it was really interesting that the men were very keen to talk about their early life experiences, and particularly early life experiences around trauma, and that included physical trauma, emotional trauma, but also racialized trauma. So the men clearly talked about how experience of racism in their early lives had had an impact on their mental health well-being in later life. Then we talked to them about their mental health experience, and here men talked about how they have experienced services as depersonalized, and where services work towards a script and not really talking to their own lives. And then I'll talk in detail about what social recovery meant for these men. So, first of all, for the men, recovery meant movement. And this was movement forward, but sometimes also backward. So it's not seeing recovery as a fixed state. Sometimes you go forward and other times you go backwards. And so it's not also reinstating a previous sense of self. The men acknowledge that once you had an experience of mental distress, you can't go back to an earlier self. That will affect you. And so, so we talked about the renegotiated identity. So it's about negotiating a new life. And it's about rediscovering agency and control. And Norman Lamb talked about this, how difficult it is for people to get control back. And this, what the men were saying for us is, you know, recovery for me is rediscovering the agency I've had earlier in my life and the control I had over my life. And so it's about a new life. That's what it means to me. Of course, I'm only starting to get to know my grandkids. So this was an older man talking about how he's rediscovering things in his life that he has lost. While it means getting out of the slump, getting work, a new place to live. So, as I say, a much more wider view on what recovery means rather than just a narrow clinical definition of recovery. For me, it's they go out of the door feeling confident about themselves so that they can apply that again to any situation. So this was one of the mental health practitioners talking about what recovery meant. Okay. So what were some of the barriers to recovery? And interestingly, we found that some of the barriers were also, if you turn it on its head, it becomes an enabler. So it's, that was really interesting. So lack of ongoing support. So particularly what men talked about is when they get discharged from a hospital admission, there was a disjointedness between what was offered in hospital and then what they receive in the community, and there was no connection between the two. But also, I already talked about the depersonalized and outcome-focused services. And what men said was, in terms of how mental health services construe recovery, it was more focusing on narrow outcomes. So medication compliance, symptom reduction, all those sort of things. And so it's very, so recovery was seen as an outcome rather than a process. Unsafe environments, so in their own relationships, but also in their communities, where the environments weren't very safe. Goodness me. Lack of personal safe spaces, lack of meaningful activity, and I think Julie talked about the importance of meaningful activity, but also as activities valued by the individuals, not activities as prescribed by mental health services. And being frozen in time, this was quite a very, very striking finding, and the men were talking about this, and so so lack of recovery, frozen in time, was about I need to get the support to learn how to unlock, not unlock, release the baggage, but I'm just afraid where that might lead. Could I manage it? If I can't, which way will I go? This was one of the men talking. And so it's about social isolation. It was about, loss of control and previous associations and hegemonic racialized masculinities. And then I think lastly about the over-dominance of medication in their lives. And they felt that these things all work together to impede their recovery. So recovery had varied meanings for men. It was about control, it was about hope, it's about trust, self-management, and importantly, it was about healing, but healing both physical and mental health, to see the two things together. And the last one was really important. In every conversation we talked to these men about, their struggle for recovery was coming off medication and staying out of hospital. And some of the men, actually, some of the interviews I did, the men could talk with a sense of pride about having stayed out of hospital for the last 5 years. And they wanted that acknowledged. So carry on with the meanings. So it's renegotiating renegotiating your identity. It's about social inclusion and about also people's hope and aspirations for the future. So the men talked about their recovery was informed by having safe spaces. Safe space to be themselves, safe space to be with other people, but safe spaces where other people can be with them as well. And this was talked about in the co-creation events and as well in the expert symposium. Meaningful positive activity, roots to social inclusion, and it's about adopting a personalised life course approach. And what the men were saying is that nobody's made connections between their early life and what's happening in their current life, and particularly as men, but also, more importantly, as black men. And we think there should be a joined-up triangle communication between all stakeholders. Okay. And just some of the men talking about being a man. So if I could give any advice to anybody, I'd say the strong thing to do, the manly thing to do is to seek help. The weak thing is to hide it. I've dropped the macho act, and I mean, I don't want to have to be Mr. Macho. She didn't marry me, he's talking about his wife, because I'm a Mr. Macho, you know what I mean. And then somebody saw Frank Bruno as a model of masculinity, but also a model where somebody shows their vulnerability. Okay. And again, so I definitely say, associate yourselves with people who support you. You might have a friend that's Mr. Hartman and believes that he shouldn't seek help, or they believe he shouldn't seek help. They believe he should brush it under the carpet. No disrespect, but you don't need people like that around. I think I've got 1 minute. So I'm going to these are just a few quotes from the men. So I've learned to love myself and also be around positive people, positive energy. The old friends I used to have, how do I overcome that barrier? How do I get past it or through? Is it by slowly distancing myself from them? That's the only thing I think anybody would have to do. So we think what's needed to renegotiate identity is safe spaces, practical support. And the men talked about not having authentic relationships with practitioners and with other people in their lives. And so it's again, we need to build that. But also meaningful activity cropped up again. And here's a man who's talking about being part of a men's group. And he said that's the other thing about the men's group. Everybody here would support. They seem to know when you were not feeling too good or when you were going through a bad spell. That's what I like about the men's group. And I think I'm near the end. So recovery we see as a process. It's a continuum rather than outcome-based and time-determined. It should start from the perspectives of black men. Co-production of recovery means involving service users, their carers, and their communities. And then men need to be provided with safe spaces in the community settings to express their vulnerabilities, explore their culture, and be supported. Thank you.
Okay, I'm going to talk about a study we've just about completed on adult safeguarding, particularly from the perspective of people with mental health problems. That's the team there. I'm here today, and Dorothy Gould and Christine Kieser, my colleagues from the team, are also here, and they'll be co-presenting. there's a disclaimer. So a quick run around a background study in aims. The CARE Act 2014 had some statutory guidance on making safeguarding personal. We wanted to find out what making safeguarding personal could and should look like in practice for people with mental health problems. We knew from looking at the literature there were significant gaps in the knowledge about mental health service user experience of adult safeguarding and their definitions of things like risk and safety. We knew a lot about what practitioners said, but very little about what service users said, particularly mental health service users. We also looked at the body of evidence around disability hate crime directed towards people with disabilities, and many of the people who were at the highest risk groups were people with mental health problems, particularly people with mental health problems living in poverty. So we thought, as part of this research, there were some questions to be asked about mental health service users' experience and concepts of what could be called disability hate crime. We called it targeted violence, hostility and abuse. What their perspectives were on about prevention and protection, and where they went to seek help if they were victims of violence and abuse because of their mental health problems. So the study structure kind of looked like this. It's a user-led study, so one of the things we wanted to do was start a user-led conversation about this issue. It was over 16 months, and this is kind of what it looked like, the flow. We did a literature scoping review. We interviewed 23 service users in depth using a pretty open topic guide about their experiences. We analysed those, did an initial analysis, and then took what we'd learned from our interviewees to some practitioners and stakeholders, so safeguarding practitioners in focus groups, who then discussed their interview findings. We then widened things out even more across social media through 2 mental health chat Twitter sessions, and you can see how many people joined in. Actually, it's a pretty good way of broadening out the conversation. So this is our interview sample of service users and survivors. We had 23 people. We were aiming at quite a decent kind of sample in terms of age, ethnicity, protected characteristics under the Equality Act, and a decent spread geographically, but you might notice that what we didn't do, and we're still trying to think through why this happened, is it was a vastly female group. So we might have to come to Frank and Paul to improve our recruitment strategy there. So the practitioner and stakeholder focus group sample, again a decent spread across stakeholders for adult safeguarding, particularly in mental health, including the voluntary sector. So Dorothy's going to talk you through our key findings and recommendations. These key findings and recommendations are a synthesis of the 3 data sets. Then afterwards, Christine will talk about how we managed to process some of the more psychological and emotional aspects of the research using creative methods.
Try and press that one to go forward.
Yeah, that's one.
Okay. Okay, so like Sarah was saying, I'm going to talk about the key findings, and we particularly draw on framework analysis to look at what the data was saying. And one thing that was very, very poignant was that the majority of service users had long experiences of abuse, some right from childhood, and these were very much based on multiple forms of discrimination, so gender identity, sexual orientation, ethnicity, socio-economic class. So over and over again people were saying, it wasn't just one thing, it was sort of multiple forms of discrimination. But at the same time, perhaps because of so many roots in childhood, they didn't feel they were worthwhile, didn't think that they would be believed because of their mental health diagnosis, and so often weren't approaching services. Very strong note was the sheer fear that people were experiencing and the sheer lack of safety people were experiencing because of hate crime. and also the sense that often abusers were really picking up how vulnerable they were and were exploiting that. It was very clear that vulnerabilities arose from a number of factors, people's whole environment. So it might be, difficulties on a particular housing estate. It might be because people got particularly labelled from some diagnoses. Someone with a personality disorder, for example, was automatically assumed to be a child abuser. Abuse going on in relationships, and also where people were trying to get help, the impact of austerity with cuts to services and therefore making it more difficult to get help. So some of the sorts of things that people said were, all my life when people have abused me, I've never cried, I've just been dead. That was a black woman. Someone else said, people talk about seeing the light at the end of the tunnel. There was no light at the end of my tunnel. Someone talking about an attack on their housing. He got a baseball bat and broke our double glazed window and put a petrol bomb in the house. So very, very traumatic material. Other findings were for service user participants, neglect was a very strong note, that neglect is a form of abuse. And also people felt particularly vulnerable in closed environments such as psychiatric wards and supported housing. Experiences of services were often difficult because people found the whole process very complicated, very fragmented, or felt they weren't really getting a response at all, and so just felt lost in the process and at further risk, further distressed, further disengaged from society. And there was a sort of some common note with staff here who also reported feeling disempowered, not confident to advocate, feeling that they were in blame cultures where whistleblowing was difficult, and a lack of adequate leadership. It wasn't that it was all doom and gloom. I mean, one service user participant, for example, spoke very warmly of a worker who regularly dropped in just to chat, say, why don't you come out and have a cup of tea? There were some positive comments about some voluntary organisations, for example, Shelter. Someone spoke of a manager who was moved to tears when they realised how much and how badly they'd been sexually abused by a worker. And service users were working very hard to help themselves, to help others through peer support, user-led initiatives, and also to influence services. But what was very clear overall was that there's a horrifying level of hate crime towards people with mental health diagnoses, and that a huge amount remains to be done to deal with that. Sarah's mentioned the Care Act, which of course is meant to prevent harm and reduce the risk of abuse, and it's also meant to ensure that people get choices and control about what's done to support them. And you'll see the three interlinking systems which what would make the system work well if they were well in place. I mean, starting with the one on the right, starting from someone's individual situation, looking at how that interlinks with the needs to be supported by mental health services, staff, organisational cultures, and then looking at the huge importance of systems and structures in society, right from government level through to social services, health benefits, police, legal systems, and also the need to deal with some heavily rooted prejudice in society. So recommendations picking up all of this, hugely important one in the first one is starting from issues that are highlighted by service users that are very important to them. Taking into account that service users and experiences of risk and abuse can be different from professionals, but that's where you need to start. starting from wishes of service users, whole person approaches, integrated approaches, and recognising that for that to happen, people need to be talking the same language between services, but also service users may have different language from professionals, so those need to be working together. And then obviously addressing what's going wrong quickly and collaboratively, and in particular taking a lead from service users and working in partnership with service users. And then other things, mental health service users need to know what safeguarding is. A lot weren't approaching services also because they didn't know what safeguarding is. They might not identify that they had been abused. They needed people to listen and believe, which so often wasn't happening, and people then to take strong action. They needed mental health staff to be willing to take responsibility, to whistle-blow, and not to be afraid of speaking up. And very strong emphasis as well on the importance of peer workers, so peers among service users, and the huge value of their role. So that hopefully gives you a sort of snapshot of the findings and also the recommendations. And I'm now going to hand over to Christine, who's going to do the third part.
Hello everyone. We're going to show you a short film in a minute, and the film was a collaborative effort stemming from the ideas and themes gathered from the voices of survivors. We believe that we could use creative media to capture and illustrate with powerful imagery topics that need to be on everyone's agenda in adult safeguarding. The artwork manages to grasp the depths of emotive traumas, the barriers in communication, and shows that isolation is a common theme. The Keeping Control study promoted the use of arts as a medium for dialogue and transitions towards achievable solutions, enabling awareness of the impact of mental health service users who have experienced it, who have experienced targeted hate crime, giving a voice and acknowledging the narratives of survivors. We also explored the use of creative writing and poetry to employ the creative diversity in communicating the wealth of narratives and solutions for change. Lived experiences can inform and become an asset in helping shape support pathways within existing services. Thank you.
I don't know if we've got time for the film. I did try and embed it really cleverly in the calendar. It did work. But I do have it on a data stick here. We can make this one.
We can talk a bit, so
We've got a couple of minutes.
Okay.
yeah.
I went to my computer. Computer. Yeah. And you,
There is a sound cut. the nature of the interviews that we undertook with the service users, we really wanted to respect them in this way as well. And all of those quotes are direct quotes from the people we spoke to, because we thought that, you know, the things that we'd heard were so powerful, they kind of deserved a bit more than just being on a piece of paper. And we will be using this as part of a learning resource for mental health workers and social workers and people who are going to get involved in adult safeguarding. So hopefully it will help change practice as well. And it was actually put together by a very good user-led arts organisation from Deep Arts in Leeds. So thank you for bearing with us and watching the animation at the end. Thank you.
Hello, Tom Collins, MSc from Marine University, Craig Boston. Is it possible to see the data set that you have, please? Or is it possible to get access to that? Is it available online?
Well, we've just submitted the summary findings to the School of Social Care Research, so they'll come out soon. I think they're in the publications process, and we're writing up 2 primary papers, so the overall findings and the methodology which will be open access. So we're kind of, we've done the analysis and we've done the writing up of School of Social Care Research, and we are currently writing papers.
No, it's just very curious considering that since 2008, 2/3 of all psychiatric lockups are men, and studies from 2014 Karen Newbeginn's research for the revision of the Code of Practice, that 81% of the most restrictive psychiatric orders are men, that you're only able to access 9% in terms of your survey of male psychiatric users.
We went through the National Survivor User Network and user-led organisations, so we didn't have NHS gatekeepers. One of the reasons we made that decision, it is a user-controlled, user-led study, and there was an element of recognition that we just want of trust. People come and speak to us, and if we were associated with user-led organisations rather than services that people may have had traumatic experience in, they might be more likely to engage with the study. We did do a small survey afterwards with a selection of our participants, and we did say we trusted you because you weren't associated with our services. We have been reflecting on the the profound gender imbalance, and we did have more men. We did originally recruit 30 or 31 people. But the men that engaged with us initially, we didn't get to follow up with them to interview, but it was still a minority. So we thought about how we conceived violence and abuse, how we spoke about it. We were all women, so we might see this differently and speak about it differently. So that's a limitation in the study, and we need to think again about communicating what we need from the research in gender terms, and thinking about how men might respond to the recruitment strategy. Maybe we use the wrong language and wrong concepts.
Or a different one.
Yeah.
We have one more question for Sarah, and then maybe we can open it up to Brian if there are any more questions for Sarah. Does anyone have any questions then more broadly about any of the presentations we had today? I know there were some people who didn't get to ask some of the questions they had earlier, and I don't know if they want to take this opportunity now to ask some questions. Well, I have one thing that I was wondering, well, Frank, because I know I'm quite short at the end, I suppose, but I was wondering if you could then we thought we were going to key message as well as the practice from the study that we've done so far.
I mean, I think the key message for practice is how do we support people to renegotiate identity? Because what the men are talking about is how, when you have the racialized experience and then you have an experience of mental ill health or mental health problems, the thing that they say services are focusing on is only the mental health experience and not the other bits of the identity. So that's a really important message, how we work with people to help them renegotiate identity. And then the safe spaces, just men talk all the way about safe spaces. And in safe spaces where they can share their vulnerability and not live up to their hegemonic ideals of what it means to be a black man in a racialized society. So it's about for the men to be safe with themselves, but to also be safe with others, and then for others to be safe with them. So that was, and then the meaningful activity. And then the giving back agency and control. Those are the key things.
I realise everyone's thinking it's the end of the day. Does anyone have any other questions they'd like to ask? Or should we go? Okay, well perhaps if we just thank the speakers then.